Okay, everybody. So welcome back to day 2 of the Peggy Lillis Foundation's virtual C. diff Advocacy Summit. I am Christian John Lillis, in case you don't know that. I'm the executive director of the organization. And I'm really pleased to have with us this afternoon two incredible researchers. We have with us Dr. Katie Suda, who is a professor of medicine at the University of Pittsburgh School of Medicine. And she is joined by Malavika Tampi, who is the manager of the Center for Evidence-Based Dentistry at the American Dental Association. As I mentioned before the break, my mother's C. diff infection was precipitated by a visit to the dentist and being given clindamycin. And so for many years, we have been trying to raise awareness of the connection between dental prescribing of antibiotics and C. diff. And last year, the American Dental Association, based on, I think, a lot of research, began to update their guidelines. And so we're really happy about that. We think it's going to really be helpful for people. And so we have Dr. Suda and Malavika here to share with you the untold history of C. difficile in dentistry. And so I'm going to turn it over to them to get started. And then, of course, when they're done, we'll be back here to do some Q&A at the end of their presentation. So take it away.
Great. Thank you, Christian, so much for that introduction. And thank you to the Peggy Lillis Foundation for the invitation for us to speak today. Next. I have no conflicts of interest, but I am receiving funding to support my research from several different federal sources. And I particularly want to highlight AHRQ and the VA, which is supporting my research focused on dentist prescribing. And the opinions expressed today are those of my own. Next. Today, Malavika and I will describe how antibiotics are prescribed in dentistry. We'll discuss the benefits and harms of antibiotic use in dentistry. We'll share evidence on the need for antibiotic stewardship in dentistry. And we'll also prevent strategies that may be helpful in optimizing the use of antibiotics in dental care. Next. Next. However, before I begin, I want to make sure that we are all on the same page and understand that antibiotics are not safe drugs. They are life-saving drugs, but they are associated with significant adverse drug events. Antibiotics are the leading factor in the emergence of bacterial resistance and the development of C. difficile. And the majority of infections caused by resistant organisms and half of C. difficile infections now occur in outpatients in the community. And unfortunately, resistant infections are only increasing, and there are few antibiotics to treat multi-drug resistant infections. And with continued limited antibacterial drug development, this is unlikely to change. Antibiotics have other serious adverse drug events, such as allergies. And these adverse drug events are a common reason for visits to the emergency department, especially in children. Now, my work showed that the majority of antibiotic use is in outpatients in the community. But up until the last 5 years, little attention has been paid to improving antibiotic use in outpatient healthcare settings. Next. Every year, there are 270 million antibiotics dispensed from outpatient healthcare settings. Now, nationally, we are seeing some decreases in antibiotic prescribing. However, antibiotics prescribed by dentists are increasing in the U.S. In fact, dentists prescribe 1 out of every 10 antibiotic prescriptions in the United States. Next. Next. And dentists prescribe antibiotics very differently when compared to medical clinicians. Dentists primarily prescribe amoxicillin, which is a narrow spectrum agent in the penicillin class. So dentists prescribe very few broad spectrum antibiotics. And we like to talk about broad spectrum antibiotics a lot because broad spectrum antibiotics have the highest risk of bacterial resistance and C. difficile. However, the second most frequent antibiotic prescribed by dentists is clindamycin. And in the US, dentists are the primary prescriber of clindamycin. Historically, clindamycin has been associated with the highest risk of any individual antibiotic of causing C. difficile. Dentists also prescribe antibiotics for different indications. My work shows that approximately 70% of all antibiotics prescribed by dentists are for preventative reasons. And this practice is recommended by clinical treatment guidelines, where dentists are recommended to prescribe an antibiotic before dental visits in patients with specific high-risk cardiac conditions. And the rationale is to prevent cases of an infection of the heart valve, which is called infective endocarditis. However, only dental visits where the patient is undergoing an invasive procedure or a procedure where the gums are moved away from the teeth need to take an antibiotic. Next. We assessed antibiotic prescribing by dentists for preventative reasons. So there's two criteria based on guidelines for an antibiotic to be needed or an antibiotic to be appropriate. First, that there's gingival manipulation. This is those invasive procedures or where the gums are moved away from the teeth. And second, that the patient have one of those specific high-risk cardiac conditions. Some examples of those cardiac conditions are a prosthetic valve or a congenital heart defect. Now, we found that 91% of patients had gingival manipulation during their dental visit, but only 21% of patients had one of those high-risk cardiac conditions. Therefore, 80% of antibiotics prescribed prior to dental visits were unnecessary or prescribed outside of treatment guidelines. Next. We looked a little closer at these unnecessary antibiotic prescriptions. So even though these antibiotics that were prescribed for prophylaxis were prescribed for a short duration of only a day or two, they were not without risk. We found that 1 to 4% of these patients had a serious adverse event within 14 days of the dental visit. And these adverse events were either an antibiotic allergy or anaphylaxis, a visit to the ED, or C. difficile. And we know this is likely a conservative estimate because we only had access to diagnostic coding for allergies and C. difficile. And in general, diagnostic coding for allergies and C. difficile is poor. One other alarming thing I found from this project. Clindamycin was more likely to be unnecessarily prescribed. And clindamycin was also more likely to be associated with a serious adverse drug event. Next. I mentioned that in our study, we only had access to diagnostic coding. But other studies conducted by public health, such as some state departments of health and the CDC, had access to laboratory data and were also able to talk to patients. These studies found that 15 to 30% of community-associated CDI are associated with an antibiotic prescribed by a dentist. Another study conducted in the United Kingdom also found that short courses of antibiotics prescribed for prophylaxis prior to dental visits were also associated with adverse drug events. This study, published by Martin Thornhill, found that single doses of clindamycin were associated with serious adverse drug events. The most common adverse drug event that was recorded was C. difficile. One other note about this is that dentists are generally not aware when their patients experience adverse events because the vast majority of these adverse events, such as C. difficile, are treated in medical settings. Next. So what can we do to decrease antibiotic-related adverse events, including the development of C. difficile and the emergence of bacterial resistance? We can implement antibiotic stewardship. Antibiotic stewardship is a set of strategies or activities to improve antibiotic prescribing by clinicians and use by patients. The CDC has also provided guidance to implement antibiotic stewardship in outpatient healthcare settings. And one of the target audiences for this guidance are dentists and dental practices. So the CDC recommends 4 components to implementing stewardship in outpatient healthcare settings, and these are called core elements. The first core element is a commitment to optimize antibiotic prescribing and patient safety. The second core element is providing educational resources and access to needed expertise. The third is action for policy and practice, implementing at least one activity or one intervention to improve antibiotic prescribing. And the fourth core element is tracking antibiotic prescribing and providing feedback to clinicians on their prescribing. Next. We applied these core elements to develop and implement the first interprofessional dental antibiotic stewardship program. And this was done at my previous institution, the University of Illinois at Chicago. We had a very strong leadership commitment from the colleges of Dentistry, the College of Pharmacy, and the co-directors of the Antimicrobial Stewardship Program at the health system. A single stewardship leader was also identified, which was to champion the Dental Antimicrobial Stewardship Program, and that was the director of the Urgent Care Dental Clinic. And the College of Dentistry also included the implementation and maintenance of the Dental Antimicrobial Stewardship Program in their strategic plan. Dentists were also provided the expertise from an endodontist, an oral surgeon, and an infectious disease pharmacist and an infectious disease physician that co-led the antimicrobial stewardship program at the health system. We provided continuing education sessions in a lecture format, as well as short educational messages that were emailed weekly for 12 weeks. These lectures and these messages focused on the treatment of infectious diseases in dentistry, antibiotic stewardship, and national antibiotic prescribing trends, as well as national resistance and C. difficile trends. Patient-focused and dentist-focused educational posters were also hung in staff areas and next to the dental chair, which is called Chairside. And these posters were intended to be behavioral nudges to influence prescribing. For actions to improve practice, we formulated local guidelines for the treatment of oral infections and provided a treatment pathway for dentists to follow. This has subsequently evolved to pathways for prescribing antibiotics for prophylaxis prior to dental visits. And recently, medical clinicians are being engaged to participate in prophylaxis decisions when the dentist is unsure. For tracking and reporting, we conducted a review of antibiotic prescribing at baseline, and this informed our initial focus of the treatment of oral infections and to focus on the urgent care dental clinic. We also assessed antibiotic prescribing post-implementation, and these results were periodically shared during clinic staff meetings. Next. We found that implementing the CDC core elements improved antibiotic prescribing in this dental clinic, with a 70% decrease in the antibiotic prescribing rate. Next. So where can dentists start? Our program was implemented in an academic setting with stewardship already widespread at the health system. However, our initial intervention, guidelines, and nudge educational posters should be feasible in most dental settings. There are also several different resources now available that are customized to dentists. We used a toolkit, which was new at the time, launched by the Illinois Department of Health. But there are other toolkits now available, such as from Massachusetts. Other states, such as Michigan and Minnesota, have a few different dentist-focused and patient-focused posters available, and some examples of those are on this slide. The CDC also has posters available customized to dentists, which we use in our program. Actually, the patient-focused poster that we hung chairside is shown here at the bottom of the slide, which is a CDC poster. And then there's also free antimicrobial stewardship training available through the CDC, and one module is focused on dentists. Next. So I wanted to share some takeaways from my experience implementing stewardship in dentistry. First, this is a significant area of opportunity that has not been explored. However, there is some national data available now that can inform future activities. However, dental primary care is not the same as medical primary care, so it's very important to consider unique challenges in dentistry. First, dentists really don't have access to their data. They don't have access to prescribing data, and very few of them are used to downloading data from their electronic dental record. In addition, dentists rarely have access to the electronic medical record. Dentists also code dental visits differently than medical visits, where dentists rarely use diagnostic coding, and this can have implications for implementing a stewardship program. Dentists are also a very unique group, where they are not only pressured to prescribe antibiotics by patients, but they are also pressured to prescribe antibiotics by medical clinicians, especially surgeons. And a colleague of mine, Dr. Deborah Goff at The Ohio State University, had a community forum with orthopedic surgeons and dentists, and they found that they were able to come to some mutual understanding of the struggles that they have in making prescribing decisions for prophylaxis prior to dental visits. And the citation for that paper is on the right-hand side of the slide. However, overall, conducting research in this space, as well as implementing quality improvement in dental practices, I have found that dentists overall appreciate just initiating the conversation, as well as the offer to help or to collaborate, because dentists have frequently been left out of the conversation to improve antibiotic prescribing. And now, to continue the conversation, I will turn over the presentation to Malavika Tampi from the American Dental Association.
Hi everyone, my name is Malavika. I am a managing methodologist at the ADA Science and Research Institute, and I'm a member of the GRADE working group. I am really excited to be here today. Thank you, Katie, for the introduction, and Christian for the introduction. I also want to mention that I have no financial conflicts of interest to disclose, and at the end we'll have time for Q&A if anyone has questions for either Katie or I. The objectives for today's presentation include being able to answer the following questions. What is the big picture of antibiotic prescribing in dentistry and the system level efforts in antibiotic stewardship, including ADA efforts? How are C. difficile infections and dentistry connected? What is the scope and recommendations of the ADA guideline? And why do these recommendations matter? So when we're talking about the big picture of antibiotic prescribing in dentistry, we have two big buckets that we talk about. So as a methods person, we were trying to work with our leadership at the ADA to figure out where do we go in terms of guideline development. And as Katie said, dentists prescribe a lot of antibiotics for preventing infections. But we also knew that there were a lot of people going into dental offices as well as urgent care centers and EDs for dental pain and swelling. And these are related to a class of conditions called pulpal and periapical conditions. And I'll get into a little bit more about what this means, but if you can imagine it, it is pretty much where someone's holding the side of their face and in a lot of pain because they have a toothache. And that's normally how patients describe this condition as well. So we knew a lot of people were coming in for these conditions to dentists and other settings. And so we decided to really consider developing a guideline with experts in this area. Now, we already had guidelines on prosthetic joint patients and cardiac valve patients. So these are patients that are heart patients or patients managed by orthopedic surgeons for the prosthetic joint patients. So we knew that there were areas that we really wanted to go, and we want to actually cover guidelines for all of these conditions that are being seen in dental offices, but again, wanting to manage and focus on the area where there were the most patients coming in. We really felt that this was related to dental pain and swelling. So the rest of this presentation is going to be specific to these types of patients, but I just wanted to put the big picture up here so you didn't think that we were forgetting about all of the other reasons patients are being seen in the dental office and being prescribed antibiotics. When we talk about dental pain and swelling, again, these are very painful conditions, and the swelling can look scary to patients. And so they're coming in the middle of the night to EDs and not only to dental offices. This approximately translates to about 2 million visits to EDs a year. And also, most of the time when these patients are going to an ED, they're being prescribed an antibiotic, because obviously ED physicians don't necessarily have the diagnostic tools and the clinical training to be able to treat dental patients and dental infections. And so we really wanted to also acknowledge that these patients weren't, again, only being seen in dental settings, but also other types of settings where dental treatment is not available. When we talk about dental prescribing of antibiotics, we know it's a lot of antibiotics. As Katie said, approximately 10% of all antibiotic prescriptions are being provided by dentists. And 30 to 85% of these are actually suboptimal or not indicated. And this means we in dentistry can do a much better job of creating guidance for clinicians that helps them make decisions regarding the use of antibiotics and the prescribing of antibiotics. The ADA is not alone in efforts to help dental clinicians make decisions for their patients, good decisions for their patients regarding the use of antibiotics. We are joining not only the CDC, but the PACCARB, as well as FTI and ASTDD in creating policies, including clinical practice guidelines, to help dentistry move forward in terms of stewardship. I wanted to note that the ADA has signed on to the CDC's AMR, or Antimicrobial Resistance Challenge, and we're really excited to launch our effort and our collaboration with the latest guideline, the 2019 guideline on dental pain and swelling. This guideline was definitely a team effort. I am a methodologist again at the ADA, and I have a wonderful team that I work with, and I have a picture of all of them later to show you. But this was done in collaboration with an amazing guideline panel. Guideline panels are a panel of subject matter experts who help methods team make decisions regarding the evidence we present to them. So this included not only dentists, but a pharmacist, which is our very own Katie Suda, Dr. Katie Suda, an emergency medicine physician, an infectious disease physician, as well as an oral microbiologist. And we really wanted to get this team together to make sure that we were coming up with the best guidance possible for our members. When we were working with the guideline panel to develop the scope and target audience for this guideline, we determined that we wanted to make this narrow as possible so that it was informative, but also we wanted to make sure that all of the target audience, we wanted to make sure that the target audience encompassed all of the clinicians that were actually seeing these patients. And so I'll quickly go through what the scope is, as well as the clinical questions we use to define the project. And so what we first did was we narrowed down our focus to the urgent management of dental pain and swelling. Again, these are patients showing up to dental clinics and other settings with a lot of discomfort caused by a toothache. We focused the patient population to immunocompetent adult patients. So children were not included in the scope of this guideline because mostly it's adults showing up with these conditions to these settings. Furthermore, we identified two different settings. Again, one where dental treatment is available, so this would be the standard dental clinic, and other settings where dental treatment is not available. We wanted to focus the audience of this guideline to general dentists, which are the ADA's main primary member, but we also understood that because other providers were seeing these patients, that we also may need to work with the wording a little bit so that they can understand our recommendations as well. These are the clinical questions that were addressed as part of the systematic review that we did to inform our clinical practice guideline. A systematic review is a collection of the best available evidence that we, the methods team, present to the guideline panel and to help facilitate decision-making or to help them formulate the recommendations that I'll be presenting to you in a second. The clinical questions were defined using the type of patient as well as the setting available. So we included, again, immunocompetent patients with vital pulp and necrotic pulp. And what this means is patients who, immunocompetent means patients who can fight a bacterial infection, and vital pulp means a living pulp inside the tooth, and a necrotic pulp means a dead tissue inside the tooth. So this is a range of conditions that encompass dental pain and swelling. Settings Where DCDT is unavailable are settings like EDs, emergency departments, and then settings where DCDT is available are settings like dental clinics. You may be wondering, what does DCDT mean? DCDT stands for Definitive Conservative Dental Treatment. And this is accepted as a standard for treating pulpal and periapical conditions, the conditions that cause the pain and swelling. Now, we know that DCDT, or dental care, is very effective in treating the pain and swelling. But oftentimes, antibiotics are still prescribed to reduce uncertainty associated with watch and wait models, because there are barriers in the health system that prevent the patient from actually getting dental care, as well as patient expectations. And so there was a big opportunity here to present to dentists, again, that dental treatment is very effective in treating these conditions. And the question the panel really had and wanted to answer was, does the addition of antibiotics to dental treatment really make a difference? Does it help the patient in any benefit? Does it benefit the patient in any way? And what are the harms associated with antibiotics as well? As we know, antibiotics are great medications, but they also cause a lot of harms. And that's why we're all here today. One of the main harms that we're talking about today is C. difficile, or Clostridioides difficile infections. Now, when we were developing the systematic review to inform the guideline panel and to help them make decisions, we were going through the data, and what we found was that there was actually a lot of data that helped support the idea that C. difficile is associated with antibiotic prescribing. For example, we saw that out of 10,000 people with a community-associated C. difficile infection in 2011, approximately 6,400 probably were exposed to antibiotics. That's not a small amount. And I have a couple other estimates around the screen as well. I'm not going to read them out, but I just wanted to show you that we were able to collect data on the connection between C. difficile as well as antibiotic prescribing. What you didn't see on the last slide was how these infections are related to a dental prescription for antibiotics. And that's because, as Katie said, this data is really hard to come by. And so we decided to provide the panel illustrative estimates of what this probably looks like based on what we know about how dentists prescribe antibiotics. We approximated that out of 10,000 people with community-associated C. diff infections in 2011, approximately 640 may have been exposed to antibiotics received from a dentist. This is not a small amount, especially when considering the fact that C. difficile infections can lead to really life-threatening issues. And so we really wanted to make sure that we had this data within our guideline project and had it neatly assembled in a way that highlighted the fact that these are estimates that really are important for decision making, policy making, and we encourage the use of dentists collecting this information, asking patients for follow-up after an antibiotic is prescribed, and then, as Katie said, accessing those records and being able to share them with researchers whenever necessary. Now I'm going to go into the guidelines recommendations. This is, again, is not the first guideline we have on antibiotic prescribing. We also produced the guideline on prosthetic joint infections related to antibiotic prescribing. That's on our website as well. But because this is the newest guideline, I'll be focusing on the dental pain and swelling guideline and going through those recommendations today. So in orange is the Chairside guide that we produced for settings where DCDT, or the dental treatment, is not immediately available. So these would be settings where the dentist can't immediately provide treatment because the patient is coming in on, let's say, a Friday night right before clinic closes, or when a patient is showing up to an emergency department. The first headline I wanted to share with you is that the guideline panel wanted to shift the focus from palliative care by way of antibiotics to dental treatment. This symbolizes a mindset shift from the myth that antibiotics can cure your tooth infection to a new mindset. Antibiotics cannot cure your tooth infection. DCDT will cure your tooth infection. Another headline that the panel wanted to share is that for palliative treatment, use of NSAIDs instead of antibiotics or opioids should be prioritized. This symbolizes a mindset shift of, I need an antibiotic and pain medication for my tooth pain, to pain can be well controlled with over-the-counter medicines such as ibuprofen and acetaminophen. The guideline panel provided a recommendation that highlighted that instead of an antibiotic being prescribed in certain situations, that the patient actually be told to take ibuprofen and acetaminophen until the patient can come in for definitive conservative dental treatment. I also forgot to mention earlier when I was talking about DCDT, these indications of antibiotics are specific for treatments where the tooth is left in the mouth. So we're not talking about when teeth need to be extracted. When in the C and DCDT, the conservative symbolizes that the teeth are being left intact and being treated, and then other strategies such as the antibiotics or now NSAIDs are being provided to manage the pain. Another headline associated with this orange chairside guide where treatment is not immediately available is to implement delayed prescribing when possible. Delayed prescribing is a new concept in dentistry, and we were really interested to present this to our members. And we would really like to hear if anyone has any comments about how this has been going. We were worried that dentists may feel challenged by presenting a delayed prescription versus an immediate prescription, because we know that a lot of times antibiotic prescriptions are provided due to a patient asking for the prescription, but evidence shows that actually patient satisfaction is not very much different between an immediate antibiotic prescription versus a delayed prescription. So we felt confident that this would be an effective strategy in helping dentists delay a prescription until the patient does either get dental care or can manage the infection in other ways. Now, the final headline is to improve referral networks and access to care for patients seeking emergency dental care. As I mentioned before, these patients are not only showing up to dental clinics, but also medical settings such as EDs. And again, this is up to 2 million visits a year. So we really want to ensure that these patients are getting the dental care they need, because more than likely just being seen in an emergency setting is going to result in an antibiotic prescription. So the ADA is also leading many efforts to ensure that referral programs are robust across the nation. Now, as you may see, the color of the Chairside Guide has changed. I'm not sure I mentioned this before, but Chairside Guides are actually a tool that we've developed at the ADA to help clinicians, dental clinicians, make decisions with their patients. They're laminated and pretty, and they have lots of colors, and the patients can talk with the clinicians chairside about the decisions that are being made. So when I say Chairside Guide, that's what I mean by that. The purple ones are for situations or settings where dental treatment is immediately available. And the first headline, that I wanted to talk about is this one on the right, which says, unless there is a localized acute apical abscess with systemic involvement, antibiotics are not required to treat a toothache. What this means is that unless the infection is at risk for spreading throughout the body, antibiotics are not recommended for patients with dental pain and swelling. And this is something the panel really struggled with, because it's a situation that dentists are facing every day. Either the patient can't get in immediately, or they're being seen in an ED, but they're at risk for the infection getting worse much, much faster than the average patient, or the patient that has a less severe form of the disease. And so what do? It's a harder situation to make a decision regarding the use of an antibiotic. So we really wanted to incorporate realistic recommendations, and this was one of the ones where antibiotics may be needed if there is risk for systemic involvement. Otherwise, antibiotics are not required since dental treatment is immediately available. Now, another headline associated with this purple chairside guide is a shift in antibiotic culture and practice. We really wanted to encourage dentists to move from the I'm going to prescribe an antibiotic just in case something goes wrong to a new mindset of I'm only going to prescribe antibiotics when they are absolutely needed. We also wanted to encourage the use of shared decision-making among patients and providers. And this is a way by which patients are treated as partners in their own care. There are a variety of tools that the ADA and other organizations such as the CDC have put out to facilitate shared decision-making between patients and their providers. And we're really encouraging dentists to use this method and help them use this method so that patients are also, again, partners in the care that are being provided, especially when it comes to antibiotic use, because we know that patients are also not only consuming antibiotics they're prescribed, but also those prescribed to members of their family or within their community. So we really want to ensure that patients understand why the provider is giving them or not giving them an antibiotic. Katie talked a little bit about what antimicrobial stewardship means, and this guideline is one of the main ways the ADA is encouraging antibiotic stewardship in dentistry. The first major point that I wanted to highlight is that we are providing first-line antibiotics as part of our guideline when antibiotics are absolutely needed, and those would be amoxicillin and penicillin. We are deprioritizing the use of clindamycin. As you can see on the flow chart, if you go all the way to the right and down, you'll see oral clindamycin right here. And the intention is to help clinicians make decisions about the antibiotics they're prescribing, in addition to whether antibiotics are needed or not. And because of the risks associated with clindamycin, we're pushing that lower down the list of antibiotics available for prescription in terms of priority. Thirdly, we wanted to encourage the identification of true penicillin allergies using this guideline. We know that 10% of the population claims a penicillin allergy, but less than 1% actually has one. And this is, again, really important because clinicians make decisions based on the antibiotic they're prescribing based off of this type of information. So we wanted to ensure that penicillin class drugs are the first line of antibiotics prescribed. So it's important to understand who really has a penicillin allergy and who doesn't. Fourthly, there's little evidence supporting the common belief that a shortened course of antibiotics contributes to antimicrobial resistance. And so we also provided guidance within our documents to ensure that patients are being asked to call their dentist back once symptoms resolve to assess whether the antibiotic needs to be continued further or not. The ADA effort was not done in isolation. I wanted to acknowledge the work of many wonderful people at these organizations, and many of them were represented on the guideline panel as well, including an endodontist, again, an emergency physician, as well as an infectious disease physician. And I also wanted to thank the Peggy Foundation for contributing during our public comment period. We were so thrilled to hear from so many members of the foundation about the importance of this guideline and what it means to them based on their personal stories. So a big shout out to the Peggy Foundation, and thank you again for providing the panel with so much great insight into why this guideline was important. A lot of the information that I presented today can be found at ada.org/antibiotics. And we not only have the guideline document, which is massive, as well as the systematic review, but a lot of these additional tools on that website as well. These include the Chairside guides, as well as an online tool to find the best recommendation for you. This is a tool that one of my colleagues developed. It's really cool. What you do is based on the clinical scenario that a dentist might be faced with, they can put in those prompts, and then it spits out the best recommendation available based on the guideline. We also understand that clinicians understand this type of information and communicate this type of information differently than patients do. And so we also created a really cool video that's again linked on the website, as well as a for the patient page, again developed by one of our wonderful colleagues. And this really helps clinicians communicate with patients about antibiotic use to help them understand that there are not only benefits to using antibiotics, but also harms, and it's written wonderfully, so please check that out. In summary, the ADA efforts are not in isolation. We are contributing to a systems-wide effort in dentistry to inform clinicians when the appropriate use of antibiotics is and when it's not, as well as engaging across the board into medicine to ensure that this is not, again, an isolated dental-focused effort. We really want to make sure that we're partnering with our medical colleagues in all of it. This was highlighted by the convening of a multidisciplinary guideline, as well as including multiple organizational stakeholders in this latest effort. The latest guideline suggests that antibiotic prescribing for target conditions that are described more generally as dental pain and swelling may provide negligible benefits and probably contribute to large population level harms, including C. difficile infections, which can again lead to high costs and death. Implementation of this guideline will help promote a mindset shift in dentistry and encourage antibiotic stewardship practices for a common dental condition such as the pain and swelling. And we're not done there yet. We definitely have our eye on doing additional guidelines on antibiotic use, and this is something that the Guideline Panel is really pushing for moving forward in terms of our priorities at the ADA. Finally, dentistry needs a system for increased reporting of harms associated with antibiotic prescribing to facilitate changes in policy and practice. So as Katie said, we're really looking forward to hearing from all of you on ways we can better collect this information and inform policy and hopefully implement the right guidance for improved practice in relation to antibiotic prescribing. This is my team on this last slide. I want to thank each and every one of them as well. This was not just me. I think they are the most fantastic group of individuals, and thank you for all of your work towards this project.
I want to again thank Mal and Katie for their wonderful presentation, and also for all of the important work that you guys have done to bring this issue to light. I mean, I really do think, you know, in addition to yourselves, I think Lori Hicks and some of the folks who work at CDC have really helped us to bring this issue of dentistry and its role in C. diff to the forefront. And so we're really grateful to you guys and to ADA for not just becoming aware of it and helping us be aware of it, but also to actually do something about it. So Susan O'Brien asks, as a patient, what is the most important document to bring to my dentist for improved practice?
So I assume that maybe this person has an indication, a medical condition, where perhaps they think that they should get an antibiotic prior to their dental visit. I would make sure you have a document that states what your medical comorbidities are. So exactly what is your cardiac condition, as an example, and take that to your dentist. Or if you have, if you think you have a penicillin allergy, have your medical clinician specifically document what your allergy was, and if it's truly a penicillin allergy.
Great. Question, can you speak more about early discontinuation of antibiotics in the management of oral infections? The topic of shorter durations of antibiotics came up during a session yesterday.
So I can briefly touch on it. When we were looking for evidence on this, it's not it didn't convince us in terms of patients being asked to finish the course of antibiotics. I think we've heard this from our parents, we've heard this from our doctors for a very, very long time. But when we actually dug into the literature, there was really no evidence to show that there was a need to finish a course of antibiotics. And we also found that when antibiotics are ingested or taken orally, that the more antibiotics you take, the greater the harms associated with that. So based off of that evidence and based off of a lot of consensus now forming from infectious disease doctors around the world, there are the panel felt more comfortable saying that the patient should call back to the dentist and ask to stop the antibiotic within 24 hours of symptoms resolving. So I think it's not a heavily researched decision at this point, but I don't think the reverse of where the patient was being asked to finish a course of antibiotics is well researched either. There's little evidence proving that should be that myth, or at least decision, should stand as is. Katie, do you have anything to add on that?
Mel, do you want to talk about that during the dental procedure that that usually takes care of the infection? So
yes, so
adding an antibiotic is adjunctive?
Right. So there are situations where the antibiotic is being taken on its own that we looked at, as well as when it's being coupled with dental treatment, because dental treatment is available. And the dental treatment really does take out the majority of the infection and resolves the infection. So there's no need for an additional antibiotic at that point. So that's why we said the antibiotic is providing negligible benefit on top of the dental treatment, but causing major population level harms. And so the dental treatment really is resolving the issue for the patient, and the antibiotic is not necessary. But to Christian's point about the shortened course of antibiotics, the research is lacking. We could really use some additional research on that.
Yeah. So I have a question. If the clinician is guided toward the use of antibiotics, do the guidelines recommend concurrent initiation of a probiotic?
They do not. And the guidelines, so Mal primarily focused on the new guidelines for the treatment of oral pain and swelling, but the other guidelines that the ADA has also participated in with the American Heart Association for infective endocarditis prophylaxis also do not mention probiotics.
And so I have a question. If I need to have a tooth pulled and do not want to take antibiotics, can you wait to see if you actually develop an infection? I had C. diff very badly and do not want it to come back. And I think that's a question that we get actually a lot, which is people who are considered cured or have not had active C. diff in a while. They are really petrified of taking an antibiotic again. And I think they struggle to understand, like, how do you communicate that to the dentist? So I'm wondering if you guys have tips on that.
Could you repeat the question, Christian, what the specific question was?
So in this case, the person is saying, if I need to have a tooth pulled, so an extraction, and they do not want to take antibiotics, can they not take the antibiotics and then sort of observe it and see if they develop an infection, then go on antibiotics? But basically, like, do they allow it to heal on its own?
So first, I would have a thoughtful discussion with your dentist about your past history of C. difficile. Remember that very few dentists have access to the electronic medical record, so they probably cannot see that in your medical history. Second, it really depends on your oral health. So one of the biggest risk factors for subsequent oral infections, as well as systemic infections, is the baseline oral health of a patient. So if you have really good oral health, meaning you brush and you floss like a boss, then and your dentist says that your oral health is good, that may be a factor that they can use. There are no guidelines for prescribing antibiotics before or after a tooth extraction for preventative reasons, meaning to prevent an oral infection. There is a Cochrane systematic review, but most of the data there is with third molars. So third molars are your wisdom teeth, which many of us get out when we're, late teenagers or young adults. And so those reviews have been criticized to apply them to all patients, especially those with really poor oral health. Mal, do you want to expand on that?
I think you did a great job. I think that's all I have to offer. The only thing I'll say is that this guideline is limited to patients where the tooth is left in. So the scope of this guideline does not include teeth that are being pulled.
All right, so we have just like another minute, so we're just going to see if we can tackle these last few questions. So is an antibiotic truly needed if you get an implant, so a dental implant?
So very similar. People, the field, my perception of the field is that tooth extractions and implants have been going together since many people are getting implants now post-extractions. Again, there are no guidelines for the use of antibiotics to prevent either implant failure or an oral infection. Again, there is a Cochrane systematic review, which the evidence does appear that taking one dose of an antibiotic before implant placement does decrease some of these implant failure and oral infections. However, the Cochrane review also found that taking that antibiotic was associated with adverse drug events.
All right, so one question is there an effective mouthwash that can be used or that has been developed in the place of antibiotics?
Mal, do you want to talk about that? I know the ADA has a statement about that, right?
I'm not sure we do. Nothing that we've incorporated as part of this guidance. I know we talked a little bit about this based off of our COVID-19 efforts at the moment with the hydrogen peroxide as well as gargling with povidone, but nothing specific to managing dental pain and swelling. So Katie, do you have any?
I know that there's not very strong evidence for this practice. I know there's some dentists who are also signed in, who are listening. So if any of you want to contribute, please feel free. I do know that from prescription data, we do know that dentists prescribe oral mouthwashes that are prescription products, but there's very little data on the effectiveness of that. And remember that the bacteria in your mouth are a good thing. Many of them are there for a purpose, kind of like your GI tract. So we don't want to get rid of all the bacteria in our mouth.
Yeah, I was going to say, I mean, they even help the beginning of digesting in some cases. So, all right, so last question, we're going to let you guys go, and we're going to pop over to networking. So do any clinicians use vancomycin as a prophylactic? They have two, this person has two clinicians that disagree on whether or not it should be used as a prophylactic.
So I assume that that is a question regarding using like oral vancomycin to prevent C. difficile. And that has been studied. The data is not supporting its use.
Okay, well, thank you guys so much. This was really a great presentation. Again, I'm really pleased that there's been progress made in this direction. I appreciate you taking the time to share that with us. So I'm going to let you guys go. Thank you so much.